Welcome to today's class, Ocular Pharmacology, Part 2. Last week, Dr. Duru Franklin lectured us on Ocular Pharmacology, Part 1, and it was really good. So, in this episode, we are going to be looking at Ocular Pharmacology and Therapeutics, Part 2, where he will be diving into different aspects and administration of drugs when it comes to optometry field and how it will help us. So if you have any question, please drop it in the chat box. And at the end of this session, we're going to go through it and clarify you on any question. So please, for the good flow of this lecture, take your pen and paper and jot down anything that you might come across as challenging. So without further ado, over to you, Dr. Franklin.
All right, good evening to everyone once again. Welcome to this webinar. So this is a continuation from the last class, the Ocular Pharmacology 1. So today we'll be talking about the Part 2. If you have any question, just drop it in the chat box. I will attend to them at the end of the class. So in Ocular Pharmacology 2, we'll focus on the ocular drugs. So the different ocular drugs, we'll be talking about the antibacterial drugs, or what you also know as the antibiotics. We'll talk about the antivirals, the antifungal, the anti-inflammatory drugs, the antiglaucoma drugs, the anti-allergic drugs, the local anesthetics, the cycloplegics, and so many of them. So I'll try as much as possible to cover a large amount of the ocular drugs we have, as much as I can. So now talking about the ocular antibacteria. So talking about the ocular antibacteria, which you also know as the antibiotics. So antibiotics and antibacteria, is there any difference? There are no difference. They are almost the same thing. It's just they are synonymous, same name. So antibacteria either kill or inhibit the growth of many bacteria which infect the body, especially the eyes, because we are talking about ocular antibiotics. So the antibacterial can be bacteriostatic or bactericidal. So the bacteriostatic are those antibiotics that inhibit the proliferation of these bacterial organisms. So what it does is it stops the growth or the multiplication of these bacterial organisms in the eye, while the bactericidal kills the bacterial organisms. So these are two kinds of antibiotics we have. So it's either the antibiotic is bacteriostatic or bactericidal. So the bactericidals are the aminoglycosides, the beta-lactams, the vancomycin, quinolones, the rifampins, metronidazole. Then why the bacteriostatics are chlorphenicol, erythromycin, clindamycin, sulfonamides, tetracycline. So antibiotics are chemical substances that can kill bacteria, fungi, and parasites. So the funny part of it is it's not just focused on the disease. It also have effects on fungi and parasites. So that is why sometimes treating a fungal infection, but sometimes, most times, or when you have a viral infection, we also include antibiotics in the regimen for treatment. So antibiotics can also have effects on fungal infections, parasitic infections, and viral infections too. So the antibiotic is just like a family name. So under the antibiotics, we have the antibacterial, we have the antifungal, and we have the antiparasitic. So antibiotics targets eukaryotic cells and the prokaryotic cells. This is the part of the cell they target in order to either inhibit multiplication of this organism or kill the organisms. So antibacteria focus on the prokaryotic cells, while the others focus on the eukaryotic cells. So classification of antibiotics, we classify based on mode of action. So for mode of action, inhibit bacterial cell wall synthesis. are drugs like the penicillins, the cephalosporins, the vancomycin, um, bacitracin, and the rest. So how these antibiotics work is it attacks the cell wall of these bacterial organisms and stop the synthesis of this cell wall. By doing this, it's it inhibits the action of this organism. So most of these organisms depend on their cell wall synthesis to survive. So this is the mode of action of the penicillins or the G penicillins we know, or we also call it the B lactams. So the B lactams are the penicillins. So we have another mode of action, which is the antibiotics that destroy the bacterial cell membrane. So these one do not attack the cell wall synthesis, do not stop the cell wall synthesis. It destroys the cell membrane entirely. So this is another mode of action. So we have the polypeptide antibiotics as one of the drugs under this classification. So the polypeptides, you can see the examples there. So please, I'll encourage you to take screenshots of this slide so that you can always revisit them, because I will not be listing these drugs as they are written here in order not to waste time. So the third mode of action in this classification is the antibiotics that inhibit protein synthesis. So examples of them are the tetracyclines, chlorphenicol, the aminoglycosides, and the rest of them. So another classification is the antibiotics that attack bacterial DNA. So example is the fluoroquinolones. These fluoroquinolones are drugs like the ciprofloxacins, ofloxacin, moxifloxacins. They are these fluoroquinolones. So they are one example of this classification. So we have another classification, antibiotics that affect bacterial intermediate metabolism. So an example is the sulfonamides. So we have other examples here. So we are going to go through some common antibacteria and their ocular uses. The chlorphenicol, the mode of action is bacteriostatic. It has good ocular penetration. It has high lipid solubility. It's highly soluble in lipid, and it's a broad spectrum. Broad spectrum, I mean, it has effects on the gram-positive and the gram-negative organisms. So it can attack both the gram-positive and gram-negative. So a broad spectrum antibiotics is one of the strongest antibiotics we have. Because with a broad spectrum, you don't need to begin to find out if the bacteria affecting the eye is a gram-positive or gram-negative. So you just go straight and treat, because this broad spectrum can settle for both. So the ocular uses, chlorphenicol, either in ointment or in eye drop, can be used in treating bacterial conjunctivitis, can be used in treating blepharitis, can be used in treating all bacterial infections of the eyes, especially those on the anterior ocular surfaces. Then the dosage. So for eye drop, fortified eye drops. When I say fortified, I mean eye drops that an eye drop that was mixed with the powder form. So fortification of eye drops involve getting a powder form of this drug and then dissolving it in the liquid form. With this, you are increasing the efficacy and the strength of this medication. So when they say fortified eye drop, means this eye drop have undergone some mixture in the powder and the liquid format. So for the fortified drop or our normal drops, it can be given 3 times daily, or depending on the severity of the infection, can also be given every 2 hours or every 1 hour for the first day, and 4 times daily for the remaining 2 weeks. So we also have the subconjunctival form of chlorphenicol. So It's in form of an injection. So this injection is applied subconjunctiva. So we also have the intravitreal form. The injection is also in form of injection administered into the vitreous. So the dosage is 1 to 2 milligrams, while the subconjunctiva is 50 to 100 milligrams per day. So this chlorphenicol have adverse effects because every drug have a side effect. So the adverse effects of chlorphenicol, whether an eye drop or ointment or tablets or fortified drops or in the intravitreal or subconjunctival format, it have an adverse effect. So one of the adverse effects is aplastic anemia. It causes aplastic anemia. It causes super infections, especially when it is abused. It can also cause Gray-Weaver syndrome, reversible bone marrow depression. So erythromycin, the mode of action of erythromycin is bacteriostatic and can also be bactericidal. So it's bacteriostatic when it's given in low concentration, and it's bactericidal when given in high concentration. So it's also a broad spectrum antibiotic. Hope you all can still see my slides.
Yes.
Okay. Then the ocular uses of erythromycin, just like the chlorphenicol, can also be used in treatment of bacterial conjunctivitis, blepharitis, and other bacterial infections of the eye, especially the external tissues of the eye or the anterior segments of the eyes, the anterior structures of the eyes. So the dosage in 45 drops is 25 milligram per mil. So 25 milligram of the solid or powdered form is mixed in 25 milligram is mixed in 1 mil. So the subconjunctiva is 50 to 100 milligram per day. The intravitreal is 500 micrograms per day. Then the ointment is in 0.5%. So once daily, usually at night. Just give me a minute. I think I need to make someone a co-host so that I don't keep on navigating to accept people in. So Jane, I just made you a co-host, so you assist me in admitting participants, please, so that I don't get distracted. Are you with me, Jane? Okay, let's go on. So looking at the adverse effects of erythromycin, one of the adverse effects is gastrointestinal tolerance. So it can cause vomiting, nausea, and diarrhea. So gentamicin, the mode of action is gentamicin is an aminoglycoside. It's a gram-negative antibiotics. It causes toxicity to the retina when given in high dosage, especially when it is abused. So it can also cause corneal toxicity, and it's also used in treating bacterial conjunctivitis and other bacterial blepharitis and other bacterial infections of the anterior surface. So as you can see here, it can be used for treating bacterial conjunctivitis, bacterial cornea ulcer, if fortified. So the dosage in eye drop is in 0.3%. So same way other antibiotics is administered 3 times daily for mild infections. So it's 3 times daily, but for more severe infections, it, let's see. Hello? Can you still hear me?
Yes, as you can hear it, Franklin.
Yes, yes, we are
Okay.
hearing you.
So the ointment is once daily at night. Based on the severity, it can be given twice daily, morning and night, for 2 weeks. So, but most of the times we give it once at night because ointments usually causes blurry vision during the day because it's oily. So it reduces vision, and we will not want, for someone that needs his or her vision during the day, you will not want to reduce how better the patient can see for that day. So that is why we always give ointments at night before going to bed. But sometimes we weigh the risk with the advantage. So if you look at this condition and the severity requires you to administer twice daily, you can do that and also inform the patients of the side effects and other things that he or she might experience. So the fortified drop is 16 milligram to 20 milligram per meal. Subconjunctival is 10 to 20 milligram per day. Intravitreal is 200 to 400 micrograms. And the shelf life is 30 days maximum. So these antibiotics, due to the preservative and the stability, it can still have its efficacy for about 30 days. But most times, the dosage is usually administered for 2 weeks. So please, you can read up other kinds of antibiotics like tobramycin, amikacin, tetracycline, and the rest. Maybe along the line, I think there are some slides that explain them. So I'll just run up quickly so that we don't waste time. So you have to read up on the tobramycin, amikacin. You can screenshot this slide so that you read it up. I have this class contains 167 slides, so I don't want to waste more time on each of the classification of ocular drugs. So I want to explain more on the most important. So for the dosage and the mode of action, the slide will be sent, or you can make screenshots so that you read up. But almost all the antibiotics, the dosage or the duration of administration is usually the same. So the only significant thing you might want to check out for is if this drug is a gram positive or a gram negative, and what is the percentage or the milligrams it has. So for the tobramycin is a gram negative. So the amikacin is a gram negative. They are used for bacterial infections. The neomycin is a broad spectrum, and the kanamycin is a gram negative. So the same usage. Tetracycline is a broad spectrum. Clindamycin is a broad spectrum. So the fluoroquinolones, which are the ofloxacin, ciprofloxacin, and all the fluoxacins, levofloxacin, they are all broad spectrum antibiotics. So you also read up or look at the side effects ranging from gastrointestinal disturbances, skin rashes, photosensitivity, teratogenicity, headache, sleep disturbance, and dizziness. So this side effect doesn't mean that anytime you prescribe these drugs, this patient must pass through these side effects. No, these side effects can differ in patients. So some patients might not experience any of it, some might experience. So the reason why you need to know the side effects is when the patient begins to complain about or any of these after you've administered a drug, there should be no cause for alarm. You shouldn't be scared because you know these are the side effects that comes with this drug. So if it's something that you need to stop, if the side effects is too much, then you can decide to stop that drug and then choose another drug with less side effects. So like I was saying, fortification of antibiotics is to intensify the strength of the medication in order to achieve adequate drug concentration. So fortified antibiotics have better inhibitory effects on pathogens than the commercially available topical medications we have. So when you fortified an antibiotics, there is more efficacy than what we buy from the pharmacies. So fortified antibiotics are mostly used in corneal infection, like keratitis or corneal ulcer. So, and fortified antibiotics are not commercially available. So they don't sell fortified antibiotics. Instead, you buy the antibiotics and fortify it yourself. So, and you must know how to fortify antibiotics before you do that. So you must know the amount of milligrams to use and per meal you need to fortify it in. So the need for fortified antibiotics is to avoid resistance of these microorganisms, especially in microbial keratitis, because microbial keratitis is usually stubborn. So when you fortify the antibiotics, the organism responsible might not be able to resist the antibiotics. So, like I also mentioned, it's for moderate to severe corneal ulcers. And also, we fortify the antibiotics, especially for drugs that are only available in parenteral form, sorry. Parenteral form, I mean, is these drugs are only available in systemic medication, in either in injections or in tablets. So we don't have, especially the drugs we don't have in eye drops. So you want to administer this drug topically. So you need to get the tablets or the IV and fortify it in any topical antibiotics so that you can administer it topically. So this is another reason why we fortify drugs. So we also fortify drugs for pediatric patients that have bacterial infections, especially bacterial infections like the ophthalmia neonatorium, the conjunctivitis of a newborn. You know, is a very severe bacterial infection. And our regular commercially available antibiotics might do little or nothing. So it is very important to learn how to fortify because most of these fortified antibiotics is the best treatment for ophthalmia neonatorium. So guidelines to fortify drug preparation. Select fortified antimicrobial based on the type of bacteria suspected for safe and effective treatment, and also not to waste this drug. So before you fortify, find out if this bacterial infection is a gram positive or a gram negative. So you then look for the drug that is in the direction of that microorganism, or you can get a broad spectrum if you can't find out if it's a gram positive or a gram negative. So you prepare this fortified drug inside a laminar air cooled room with precaution. So disposable syringe is used to, especially if you want to dissolve or you want to fortify an IV into an eye drop. Can you all still hear me?
Yes.
So especially if you want to fortify it, so you use a disposable syringe to avoid cross-infection from another patient or from another procedure you've done with that syringe. So you also state the date of preparation and date of expiry of that drug. Like I was saying in the last class, once you open a drug, degradation of that drug starts immediately as immediately as air touches that drug. So the expiry date of a drug is valid if that drug is open. But once a drug is opened, the expiry date is usually within 2 weeks to 1 month. So that is why it's important to state the dates you prepare this fortified drug so that you know when it has degraded. So you know 2 weeks from that day or 1 month from that day that this drug is no longer active. And you also state the expiring date so that you'll be sure that the drug you fortified with is not an already expired drug. So the drug should be refrigerated and kept under 4 degrees centigrade for 7 days. And also, whenever you want to, you shake very well before installation. So this is how we fortify our gentamicin. So you get you take 2 ml of the IV intravenous gentamicin, which contains 40 milligrams per ml, and add it to a 5 ml bottle of the commercially available gentamicin we have in eye drops, gentamicin of 0.3%. So when you get this IV, you take up 2 ml of it and then add it to a 5 ml bottle of your gentamicin, 0.3%. Then refrigerate it and shake well before installation. So you can do the same for tobramycin. And to fortify vancomycin is in milligrams, is in tabs. So you add 5 milligrams of vancomycin to 33 ml of 0.9% sodium chloride, or if you don't have the 33 ml of 0.9% sodium chloride, you use an artificial tears. So you dissolve a 500 milligram into an artificial tears to produce a solution of 15 milligram per ml. So you refrigerate and shake well before installation. So for the amphotericin B eye drops, so you add 10 ml of distilled or sterile water to the tablets, the amphotericin tablets of 50 milligram. So it's either in tablet form or you ground it in powder form, or it also comes in powder that is usually dissolved in saline water for injection. So whichever way you can get this amphotericin tablets or powder, you get it. So you dissolve it in a 10 ml distilled or sterile water. So then you draw 3 ml of this and add to a 7 milliliter of artificial tears. So this is the fortified preparation you'll be using for your topical treatment. So you refrigerate and shake well before installation. So disadvantages of fortified antibiotics: it causes epithelial toxicity because this antibiotics is in high concentration. So it retards epithelial healing, especially when you're using the aminoglycoside and vancomycin. So in large epithelial defect or conjunctival ulcers, the frequency of drug therapy must be reduced. So when you are treating corneal ulcers or conjunctival ulcers, especially when the ulcer is very severe, you reduce the dosage, because as you are treating the infection, you might be disrupting or slowing down the healing of this ulcer. So it's better you reduce the dosage or the frequency of the drug. If it's something you want to administer every 2 hours or 4 times daily, you can reduce it to 3 times daily or twice daily, depending on the severity. So now we're looking at the reasons why ocular antibiotics treatment fails. One is drug resistance. So most times our treatment fails because this patient is resistant to drug. Most of you will agree with me that, especially the ladies, and it's not even specific to the ladies, everyone, sometimes if you go for check tests, medical tests, especially most times they check you for drug resistance. You see that some people are now resistant to some antibiotics. In the test results, you see resistant to ciprofloxacin, resistant to gentamicin, resistant to this. So when you're resistant to a particular drug, and that drug is given to you for treatment, the treatment will fail. So when a patient is resistant to a particular drug, the treatment fails. So that is why it's important to advise your patients not to abuse antibiotics. Most patients, whenever they have any eye issue, not really eye issue, any condition at all, systemically or ocular infections, they run to the pharmacist and get an antibiotics immediately. And with that, they will abuse the antibiotics, especially when this infection is on a particular spectrum of bacteria, especially if you're on the gram positive and you're using a gram negative to treat, and nothing is happening. You keep on using that drug in order to see the effects. And the process, you abuse that drug. So any day you want to use that drug, or that drug is recommended for you for treatment, you have become resistant to that drug, and that drug will fail. So this is how drug resistance affects the efficacy of treatment. So another thing is inaccurate diagnosis. So if you diagnose a patient that have allergic conjunctivitis and you are diagnosing it, you made a diagnosis of bacterial conjunctivitis and you are treating with antibiotics, you might not get any effect. So the treatment will fail because you gave an inaccurate diagnosis. So when treating with antibiotics, make sure the diagnosis is a bacterial infection. So inadequate dose. So if you are not using the adequate dose and prescription, or you do not administer the adequate dose, you might get little or no effect from the treatment. So it's very important to know the dosage and how to prescribe antibiotics. So poor immunity of patient. For patient that is immune compromised is difficult to treat with antibiotics, because as we are treating with antibiotics, the immune system is supposed to assist in resolving the infection. But in a situation where the immune system cannot do anything, patient is just depending on the antibiotics, especially when the doctor is not aware that this patient is immune compromised, and the doctor is prescribing these antibiotics the same way he will prescribe the antibiotics to someone that have a good immune system. The effect it will have on someone with a good immune system will be different with someone with a compromised immune system. So patient non-compliance too makes treatment fail. So when the patient does not comply with the prescription or don't take the drug as administered as prescribed, the treatment will fail. So another reason why treatment fail is shelf life. So when the drug is expired, or after opening a drug and it have lasted for 2 weeks or more than a month, depending on the drug, the shelf life, it have elapsed this shelf life. So it's a treatment to fail. So now let's go to ocular anti-inflammatory drugs. So the anti-inflammatory drugs are classified into 3. We have the corticosteroids, or what you also know as the steroids. We have the non-steroidal anti-inflammatory drugs, the NSAIDs, and we have the immunosuppressive agents. So these 3 classes of drugs helps to treat inflammation. So we already know what inflammation is, and we know what anti-inflammation means. So anti-inflammation means you're resolving an inflammation. So an example of corticosteroids is the glucocorticoids, and another is the mineralocorticoids, and the third is sex hormones. So only the glucocorticoids are used in ocular treatments. The rest are usually natural corticosteroids found in the body. So the corticosteroids has no specific anti-inflammatory action. There's nothing like what we said in the antibiotics that is gram positive or gram negative, or it attacks so parts, or it has a specific mode of action. No, So the corticosteroid has only one mode of action, which is to resolve inflammation. So they resolve inflammation without regard to cause, whether it's an infection that is causing inflammation or is a trauma or whatever is causing the inflammation, it resolves it. So they also suppress inflammatory processes like hyperemia, vascularization, fibroblastic proliferation, and cellular infiltrations. So for cases of neovascularization, corticosteroids can help to resolve the neovascularization, hyperemia, redness of the eye. Corticosteroids can serve. So indications for steroids for blepharitis. So we know that any condition that ends with itis is an inflammation. So blepharitis is an inflammatory condition. So anti-inflammatory drugs are required. So corticosteroid is one that can be used. Allergic conjunctivitis or venous conjunctivitis, anterior uveitis, episcleritis, scleritis, hemangioma, traumatic inflammation of the eye, corneal inflammation of the eye caused by thermal burns. Please, I will repeat this: corneal inflammation caused by thermal burns, chemical and radiation. So these are the corneal conditions that corticosteroids can be used. But corneal conditions like corneal ulcers or foreign treatment after foreign body removal, we don't use corticosteroids. So all inflammatory conditions of the anterior segment of the eye, we use corticosteroids. Contact dermatitis of the lids, laterogenic eye inflammations, post-operative treatments, like we use steroids after surgical treatments of the eye, like our cataract surgery, phaco emulsification, or our laser surgeries. So also non-specific keratitis, we use steroids. Pontic keratitis, herpes zoster keratitis, we use steroids. So the contraindications for steroids is contraindicated in acute superficial herpes simplex keratitis, but herpes zoster keratitis is indicated for steroids, but herpes simplex keratitis is contraindicated for steroids. So fungal infections or any bacterial infections of the eye is contraindicated. Viral infections of the cornea and conjunctiva is also contraindicated. Ocular tuberculosis is contraindicated. Superficial corneal foreign body removal, like I said before, is contraindicated. Any patient that is hypersensitive to steroids is contraindicated. So acute purulent conjunctivitis is a bacterial conjunctivitis, is contraindicated, like I said. So pregnancy and lactation, when using steroids, you need to use it with caution. So general principle of steroid, we administer the minimum effective dose used for the shortest time possible. So we usually administer the minimum effective dose that can be used for the shortest time possible, because a steroid is a very strong drug, and it has a lot of side effects and some other ocular complications, because it can put you at risk. Abuse or prolonged use of corticosteroids can cause cataract formation and put you at risk of glaucoma. So it is very important we use the minimum effective dose for the shortest time possible. And a steroid should not be stopped. So there's what we call tapering of steroids. So when you want to stop the medication, when you administer the medication, on stopping the medication, you taper the dosage so that the patient will stop this medication gradually till the last dose. Because if you stop abruptly, there's a rebound effect. So if it is a case of inflammation, the inflammation will come back and in a severe state. So when you are administering, you need to have strong knowledge of pharmacology. You need to have clinical experience before administering corticosteroids. And you should also watch these patients. Follow-up visits is really necessary to reassess the eye during the course of this treatment. So you frequently reassess the dosage, the therapy effects, and possible adverse effects on every follow-up visit. So you individualize the dose. You can also add a systemic steroid in cases of posterior inflammation, posterior eye inflammation. So you can go for a systemic steroid, or any anterior segment eye diseases or inflammation that is proving difficult to resolve. You can also add a systemic steroid. So, and you should also make sure that this patient is compliant with this drug. So you ensure compliance. For moderate to severe anti-inflammations, use higher strengths. So do not extend therapy. Do not extend treatment for more than 3 to 4 weeks in mild to moderate ocular inflammations, especially the external ocular inflammation. So it's usually administered for 2 weeks or at most 3 weeks. So do not exceed 4 weeks for mild to moderate external ocular inflammation. So our corticosteroid can be in form of eye drops, ointment, injections, tablets, or a systemic format. So for acute inflammation, the dosage is 1 drop or 2 drops, but I usually prefer 1 drop because most times administering 2 drops at a time is wastage, because the phonix is capable of containing 1 drop of an eye drop. So administering 2 drops can be a waste. So 1 drop every 1 hour daytime for acute inflammation, or you can do 1 drop every 2 hours, 2 hourly at night when you are using the ointment. For moderate to mild to moderate inflammation, 1 drop every 4 to 6 hours, which is 3 times daily, or 4 to 3 times daily. You can do it you taper it down to 2 weeks. So you taper over several days, and so like I said, rebound effects can occur if you stop abruptly. So ointments for acute inflammation. So how you apply it is you apply 18 coats in the phonix of the patient. You ask the patient to apply 18 coats in the phonix 3 to 4 times daily, usually at night, or it's better administered at night. Or if you can't do 3 to 4 times daily, you can just do once daily at night. So for moderate to mild inflammation at bedtime is okay. So an example of our corticosteroid is prednisolone. Another example is betamethasone, which is in sodium phosphate solution, 0.1%. So there is high risk of spike of IOP. Like I said, if you abuse corticosteroids, it puts you at risk of glaucoma. So because steroids increase intraocular pressure when used for a long time. So it's important that you check the IOP before you administer steroid. If it's a patient that is ocular hypertensive, you take caution. So it have a better ocular penetration. Hence the reason for IOP spike. Another example is dexamethasone. Another example is hydrocortisone, triamcinolone, sorry, and remexolone. So you just make screenshots and you read. So for prednisolone, 1 drop every hour at daytime, or you can give 1 drop every 2 hours at night and you taper down for 2 weeks. Then other dosage is written here. So I'm just trying to be fast because we have a lot of slides to go through. So these are other forms of steroids. So the furoate alone is the most powerful corticosteroid, the topical corticosteroid. Yeah. So it's the new generation steroid, and there's low risk of IOP spike. And that is why it is safer, and there is rapid absorption. And once sweet thing about it is that it soothes and cools the eye, and it enhances patients' comfort. So that is why most doctors always like prescribing furoate alone. So this is a table showing the half-life and the grading of the anti-inflammatory effects of each of these drugs. So we also have another classification of ocular drugs, the surrender antibiotics combination. So the combination of steroid and antibiotics provides powerful anti-inflammatory effects and broad spectrum bacterial effects, especially for cases that conditions that have to do with a bacterial infection and an inflammation at the same time. If you must, like I said, you always weigh the risks over the disadvantage, the risks over the advantage. So if the advantage is better than the risk, you can take caution in prescribing steroids, especially for mild bacterial infection. So if the inflammation is not resolving with just antibiotics, you can go for steroidal antibiotics and you administer. So this kind of drugs, this kind of drug combination is really powerful for anti-inflammatory effects that have to do with bacterial infection. So there are some antibiotics that are inactivated by pus and exudates from bacterial infection. That is why when prescribing antibiotics for patients with mucopurulous discharge, first of all, you irrigate the eye or clean up the eye of this pus. Because if you just administer antibiotics, these antibiotics will be inactivated by the pus. So it's very important that you take note of this. So, but when you prescribe external antibiotics, cautiously, this pus cannot inactivate this antibiotics combination. So indication for steroid antibiotics is in anterior segment inflammation, treated with bacterial infection, chronic anterior uveitis, cornea injury from chemical radiation and thermal burns. Take note, cornea injury from chemical radiation and thermal burns, not foreign body removal or corneal ulcer. And also in pre and post-operative phase of where bacterial infection exists. So these are the types: dexamethasone, neomycin, betamethasone, neomycin, hydrocortisone plus gentamicin, prednisolone plus gentamicin. So these are the examples of steroid antibiotics combination. So common ocular complications of topical steroids. So like I said, it can put you at risk of cataract if abused or prolonged use. It also increases IOP. So it reduces resistance to viral. It causes resistance to viral, bacterial, and fungal infection. So that is, it puts you at risk of increased risk of infection. So like I said, if you are treating a bacterial or fungal infection, it's better you avoid a steroid. If you must, you should go for a combination. So it also causes dry eye. abuse, prolonged use, can cause ptosis and mydriasis. Mydriasis, I mean, is dilation, dilated pupil. It can also cause eyeball perforation if used in cornea or sclera that is already thinning. That's why I said in compromised corneas like cornea ulcer or foreign body removal, you should avoid steroid. If not, you put that cornea at risk of perforation because that region is already thin. So it can worsen stroma melting, cornea stroma melting. So now we are at the non-steroidal anti-inflammatory drugs. So NSAIDs are anti-inflammatory drugs that affect certain nerve endings. So they give symptomatic relief of itching by suppressing inflammation without modifying inflammatory etiology. So in this kind of NSAIDs can be used both in bacterial infections and fungal infection, whether the inflammation is a result of infection or not. So it can give symptomatic relief. And also cases of itching. So it's free of adverse effects, unlike the steroids. Or it has less adverse effects, unlike the steroids. So it also have anti-inflammatory, besides anti-inflammatory effects, it has the analgesic effect and the antipyretic effects. So the mode of action of NSAIDs is that it inhibits the cyclooxygenase enzymes, thereby interfering with the prostaglandin mediators of the late phase allergic response. So this is how it inhibits itching and inflammation. So example of our anti-inflammatory drugs is our ketorolac, which we can find in eye drops. Floripropane is also in eye drops. Our indomethacin is also see it in eye drops. Diclofenac can be in eye drops and tablets. Nepafenac can be in eye drops too. So all these are our NSAIDs. They are used topically. So NSAIDs can be used systemically when high ocular concentrations are desirable. So when the inflammation is very severe and then the topical mode is not resolving it as you want, you can go systemically too. So it's also well absorbed orally, just like our steroids. So it has good ocular penetration too. So it can also cause a side effect that we call systemic toxicity. So that is why NSAID is advised or contraindicated for patients with ulcer because it exacerbates the ulcer. So this is where the systemic toxicity comes in. So NSAID can also cause cornea melting, especially in patients with prior ocular diseases like cornea ulcer or cornea thinning. So for this reason, it is used in acute allergic conjunctivitis. For its reason, its use in acute allergic conjunctivitis should be limited to occasional use in patients who do not respond to other agents. The reason why they mention this acute allergic conjunctivitis is because in patients with acute allergic conjunctivitis, there is a tendency of cornea thinning. So that is why most patients that we treat, is very important we take caution when treating patients with VKC, because if you check the cornea topography or the thickness of the cornea of this kind of patients, you notice some thinning. So when you not try to treat the itching with an NSAID, there's a tendency of cornea melting. So the frequent use of NSAID in such kind of patients is not advised. So NSAID can also be in ointment. Besides being in eye drop, it can also be in ointment. The example is phenylbutazone. and our oxyphenylbutazone. So eye drops are diclofenac, bromfenac, ketorolac. I've mentioned all this. So they are used, can be used 2 times daily. Bromfenac can be used 2 times daily. Ketorolac 0.5% can be used 3 times daily, and diclofenac can be used 4 times daily. So depending on the drug you are using, well, the dosage can also depend on the severity. So most times I commonly prescribe NSAID twice daily, no matter the eye drop I use, in cases of mild inflammations. But in severe inflammations, I go higher to 3 times daily, depending on the eye drop I'm using though, and the percentage. So nepafenac 0.1% 3 times daily. So nepafenac can also be in suspension, and indomethacin can also be in suspension. So floriprofen is also one. Ibuprofen too is also another example. So you can go through this to read up these other NSAIDs and their dosage. So ocular indications of NSAIDs is NSAIDs can be used in uveitis, scleritis, and fixed scleritis, reduction of post-operative inflammation. So besides using steroids, you can also use NSAIDs. So maintenance of intraoperative mydriasis, reduction of discomfort after refractive surgery, prevention and treatment of aphakic and pseudoaphakic cystoid macular edema, and also for allergic and venous conjunctivitis, but with caution in cases of corneal thinning. So the third class of anti-inflammatory drug is immunosuppressive drugs, otherwise called the anti-rejection drugs. So these drugs are prescribed for patients that undergo transplants, either corneal transplant or conjunctival grafting or any form of transplant. So because when you do this transplant, there is high immunologic response by the body. So in this immunologic response is the body is trying to reject that. The body sees that transplanted tissue as a foreign body, so it's trying to reject it. So these immunosuppressive drugs are called anti-rejection drugs. So they're given to suppress the inflammation as a result of this immunologic response. So they can also be a class of glucocorticoids that suppress the strength of the body's immune system, like I mentioned. So these drugs are used to make the body less likely to reject a transplanted organ, such as liver, heart, or kidney in the eye, in cases of corneal transplant. So the systemic types are often used to treat autoimmune disorders, such as lupus, psoriasis, rheumatoid arthritis, Crohn's disease, multiple sclerosis, and organ transplant. So it can be used in place of corticosteroids in inflammation if you can't reach corticosteroids. So like I said, corticosteroids can also, immunosuppressive drugs, corticosteroids can also be one example of immunosuppressive drugs. So prednisolone is an example, cyclosporin A, antibodies like anti-VEGF, infliximab, ranibizumab, and other anti-VEGF drugs are examples of immunosuppressive drugs. So another example under immunosuppressive drugs is antimetabolites. So mitomycin C, I know this one might be very common with you. So this mitomycin C is the one we use for conjunctival grafting after pterygium excision. So in order to reduce inflammatory response or the the process of the body rejecting that conjunctival grafting, we administer mitomycin C. So these are other examples of anti-metabolites. So the anti-VEGFs are used in eye care too. So they are antivitreal infusions. They are IV injections. They are administered antivitreally for cases of retinopathies. Retinopathies also. So ocular indications of infliximab are non-infectious scleritis, Facet disease, sympathetic ophthalmia, malignancies, bedshot chorioretinopathies, and diabetic retinopathies, hypertensive retinopathies, and severe ocular rheumatoid disease. Scleral malacia perforans, neovascular age-related macular degeneration, retinal vascular tumors, retinal vasculitis caused by sarcoidosis, myositis too. So they prevent the binding of VEGF. VEGF means vascular endothelial and growth factor. So they prevent this VEGF from binding with its receptors on the endothelial cell, thus inhibiting cellular proliferation or formation of new blood vessels. So they inhibit new vascularization in cases of retinopathy or macular degeneration. So VEGF has anti-angiogenic effects. So I think I'll just rush through this. So the clinical indication of VEGFs, anti-VEGFs are for wet macular degeneration, diabetic retinopathy, especially the proliferative form, the neovascular glaucoma, retinopathy of prematurity, glaucoma, neovascularization. So same thing with other anti-metabolites. The date for administration. So they inhibit the use of a metabolite, which is another chemical that is part of normal metabolism. I think you just screenshot this and read through. This is not. I should have removed this from the slide. This is above. This should be in part 3. So the complications of these immunosuppressive drugs are: 1, cornea and scleral ulceration. It can cause burning pain. It can lead to secondary glaucoma and scleral calcification. So now we are going straight down to the anti-glaucoma medications. Are you all still following?
Yes, yes.
So right on. I hope you are not tired. So anti-glaucoma drugs are IOP lowering agents. So these drugs, we have different classes. We have the first class that reduces aqueous humor production, which are the example are the beta blockers, like betazolol, fatiolol, levobunolol, metipranolol, timolol, all the law of them. They are beta blockers. So their action is to reduce aqueous humor production. I will explain how they do that. Then another class of drug under this classification that reduce aqueous humor production is the alpha-2 agonists. So the alpha-2 agonists like albuminidine and apraclonidine. So they reduce aqueous humor production. So another class of drug under these two are the CAI, the carbonic anhydrase inhibitors. So example is the brinzolamide, acetazolamide, ozolamide, and metazolamide. So Azox, Diamox, Susox, and Neptazine. So another class of drug under this is epinephrine and their analogs. So The pivefrin, or what we popularly call propine, is one example. The epinephrine is another example. So like I said, there are three basic mechanisms of anti-glaucoma medications. The first is they suppress or they lower aqueous humor formation or aqueous humor production. The second mechanism is the anti-glaucoma drug can increase trabecular outflow. So the increase of trabecular outflow is another mode of action that some anti-glaucoma medication take. Another mode of action that an anti-glaucoma medication can have is the increase of uvoscleral outflow. Are we following?
Yes, sir. Yes, sir.
Yes, we are.
So drugs now that increase aqueous humor outflow. Aqueous humor outflow are one, the prostaglandins. Example is our bimetopros, latanoprost, tafluprost, travoprost, prostones, and the latanoprostins. Another example is our cholinergics. Under cholinergics, we have the carbacols, the ecothiophates iodide, we have the physiostigmine, and we have the pilocarpines. Also, the pivefrins and the epinephrines can also have this mode of action that increases aqueous humor outflow. So now we're explaining each of these classifications one by one and their mode of action. So the prostaglandin analogs, like our travoprost, latanoprost, and the rest, so they are prodrugs of potent agonists of the prostanoid prostaglandin receptors. Are we following? So they are prodrugs or they are agonists of the prostanoid prostaglandin receptors. So FP receptors, or we have different subtypes of prostaglandin receptors. We have I call it the DEP-TIP, the DEP-FIP, DEFI, DEFIT, sorry, DEFIT. So we have the D prostanoids, we have the E prostanoids, we have the F prostanoids, the I prostanoid, and the T prostanoids. So these prostaglandin analogs are agonists to the F prostanoids receptors. So example of them is the latanoprost and travoprost and uniprostones. So they lower IOP mainly by enhancing the uvoscleral outflow. So that is the aqueous outflow without significantly affecting trabecular outflow. So let me explain the difference between uvoscleral outflow and trabecular outflow. So trabecular outflow means the trabecular meshwork is being enhanced or is being opened for aqueous humor to drain very well. Why the uvoscleral outflow means the ciliary body is the drugs affect the ciliary body to absorb the aqueous humor in order for this aqueous humor to drain through the ciliary body and the sclera out of the eyeball. So it's either this aqueous humor is draining through the sclera and the ciliary body, or is draining through the trabecular meshwork. So the uvoscleral outflow is not the conventional drainage system of the aqueous humor, but the trabecular outflow is the conventional drainage. So it's the normal drainage. But this uvosclerar outflow is usually activated by drugs. So if you don't give drugs that activates it, the aqueous humor will not drain through the uvosclerar outflow. So it can only drain through the trabecular meshwork. So these prostaglandins enhance uvosclerar outflow, but not the trabecular outflow of aqueous humor. So this is the mode of the prostaglandins. So, but one of the prostaglandins, which we call the pimatropos, is now reported to have both mechanisms, both the trabecular outflow and the vascular outflow. So it have ability of enhancing vascular outflow and also trabecular outflow. So they produce lower IOP lowering effects. Our uniprostones is considered the less efficacious prostaglandin we have. So it have low effect than other prostaglandins. So normally our prostaglandins are administered once daily, usually at night. But our uniprostones is administered twice daily. And it's usually the second line of drug. But our other prostaglandins are usually the first line of drug during glaucoma treatment. So travoprost Z is another example. So the Z means that these travoprost have the beta-choline chloride as a preservative. So it increases vascular outflow, is used once daily. So the side effect is redness, iris discoloration, and also eyelash thickening. Some ladies in our midst will agree with me that some of them usually abuse our prostaglandins in order to make their eyelash grow longer and fuller and thicker. So that is a wrong that is a wrong mode of administration of that drug. But it's important for you to know that prostaglandins enhances eyelash thickening and growth, and also changes iris color. So when you begin to see these changes, our patient begins to complain of these changes after prescribing this drug, you should know that these are the side effects. So if these changes cannot be tolerated by these patients, you stop the medication. So timolol is under the beta blocker. So it's used to decrease IOP. So it's one of the first line of action we know since 1978. So for the past 20 years, we have been using timolol as the first line of action before the discovery of prostaglandin analogs. So timolol or other beta blockers, they decrease aqueous production. So they decrease aqueous production. They are used twice daily. Side effects are on the lungs and the heart. So patients with heart issues are contraindicated for beta blockers. Patients with asthmatic patients or patients with any lungs or pulmonary conditions are contraindicated for beta blockers. And also beta blockers are administered with caution in hypertensive patients, especially hypertensive patients that are already taking hypertensive medication. So you avoid administering beta blockers. So another side effect is shortness of breath and bradycardia. So that's why asthmatic patients and patients with heart problems are contraindicated for timolol or other beta blockers. So brimonidine is one example of the alpha-2 agonists. So, and another name for brimonidine is alphagan. So brimonidine reduces aqueous production. It reduces aqueous production. So it's also a first line of drug. It can also be used in conjunction or in combination with other classes of drugs too, depending on the level of the glaucoma. And it's also have a neuroprotective ability. So it has discovered that it have a neuroprotective ability of, though it's still many studies are still going on to approve this. So, like I said, it's an alpha-2 agonist. So it has less stinging effects and less redness as a side effect. So it's administered 1 drop twice daily or 3 times daily, depending on the severity of the eye pressure. So another side effect is it can cause uveitis if abused, and it can cause dry mouth and then fatigue. It can also cause sedation too. So this beta-zolol, levobunolol, and the other laws are under the beta blockers. So the beta blockers, or also called the beta adrenergic blockers, their mode of action is that they bind with the adrenergic neurotransmitter like norepinephrine and epinephrine in order to reduce aqueous humor production. So using glaucoma, so now is less efficacious than the prostaglandin. So the prostaglandins are stronger than the beta blockers. Used in primary open angle glaucoma and also angle closure glaucoma. Another classification is alpha-2 agonists. I've already mentioned them. They are brimonidine and they are praclonidine. So it can be used for both open and closed angle glaucomas. They have rapid onsets and they have maximal effect on ocular hypertension within 2 to 3 hours. So the effect starts immediately within 2 to 3 hours and with maximal effect. So it's called the alpha-2 agonist because they selectively activate the alpha-2 adrenergic receptor of the ciliary epithelium, which leads to a reduction in the intracellular cyclic AMP levels. So AMP is the adenosine monophosphate levels, and they eventually suppress aqueous humor production. So our TAIs, or the topical carbonic anhydrase inhibitors like the brinzolamide, acetazolamide, dozolamide, all the zolamides, they also reduce aqueous humor production by inhibiting the carbonic anhydrase in the ciliary epithelium. Remember, the aqueous humor is usually produced by this ciliary epithelium. So this drug inhibits the carbonic anhydrase inhibitors in the ciliary epithelium and reduce the production of bicarbonate ion. So these carbonic anhydrase inhibitors, these carbonic anhydrase enzymes is responsible for bicarbonate ion formation, which is responsible for aqueous humor production or formation. So when these carbonic anhydrase enzymes are inhibited, the bicarbonate ion production is reduced, and IOP and aqueous humor production or formation is reduced also. So this is the mode of action of this is the mechanism of action of carbonic anhydrase inhibitors. So our cholinergics, example, Carbachol, ecothiophate iodide, physostigmine, and pilocarpines, that are used as supplementary treatment for open and closed angle glaucoma. So the mechanism of action is that they stimulate the muscarinic cholinergic receptors in the ciliary body and iris to cause contraction. So in cases of patients with large pupil size or dilated pupil and narrowed angle or closed angle glaucoma, pilocarpine or these cholinergics are administered to constrict the pupil. So they constrict the pupil by stimulating the muscarinic cholinergic receptors in the ciliary body and iris in order to cause contraction of the muscle responsible for constriction, and the angle for drainage is opened for aqueous humor to drain properly. So during this constriction, also help in opening the trabecular meshwork to increase aqueous outflow. So, and the constriction also helps in breaking synechia in cases of primary angle closure glaucoma too. So the epinephrine and the other analogs, like example, the pifevrine or propane or the epinephrines, They bind to activate various adrenergic receptors subtypes. So when they bind with these adrenergic receptors, they suppress aqueous production and increase outflow too. So I think after the antiviral, I will stop. Then we'll continue some other day. I think our time is fast spent. So our antiviral drugs, they are virostatic, like I said, in bacteriostatic. Bacteriostatic means these drugs inhibit multiplication of or proliferation of this organism. So when I say drugs are virostatic, it means it inhibits viral replication. So uses is for viral conjunctivitis, in conditions like viral conjunctivitis, herpetic keratitis, dendritic keratitis, because all these conditions I'm mentioning are viral, are conditions as a result of viral infections. So antiviral medications are used for viral infections. So superficial punctate keratitis is also an example, and cytomegaloviral infection. Example of such drugs, antiviral drugs is our hydroxyuridine, 0.1%, can also be in 0.5% for the ointment. Our cyclovir, 3% ointment. Our vidarabine, our valacyclovir, which is in tablets, and other antiviral drugs. So our ganciclovir can also be in injection form, intravitreal form, and in gel. So whenever most of the antiviral medications always ends with, most of them, but not all, always ends with VIR. So when you see VIR as a suffix, you know that this is an antiviral medication. So these are examples. I think let me just add this to the end part. So antifungal drugs is another classification of ocular drugs. So they have poor intraocular penetration. They have side effects, a narrow spectrum. They also in administering this medication, because of they have poor intraocular penetration, the debridement of that surface is usually required in order to facilitate ocular penetration. What I mean by debridement or debridement, for cases like debridement means peeling off the wound on that surface. So you must have seen in some injuries before treating, the doctor tried to peel off the dried part of that wound before administering treatment. Why? To facilitate penetration of that drug. So in administering antifungal medications, it's very important that you, because of this low ocular penetration, it's very important that in cases that you need to do debridement, you do it in order to have full efficacy or effect of that drug. And because of the poor intraocular penetration, there is usually do a prolonged aggressive treatment. Example is our types of antifungal is the statin, used for candida and aspergillus infection. So it's a narrow spectrum and has poor penetration. Another example is amphotericin B. It's a broad spectrum antifungal drug, and it's fungastatic and fungicidal too. So depending on the concentration of the drug. So for lower, when you give a lower concentration, it's fungistatic. When you give a higher concentration, it becomes fungicidal. So used in cases of candida infection, histoplasma infection, cryptococcus infection. So all these are fungal infections. So anatamycin is another example, is a broad spectrum It has this one that have better ocular penetration. So for candida treatment or infections as a result of cephalosporins. So it's only available in ophthalmic form or topical form, but no systemic form. So I think I will stop here. Then from our next class, we'll continue with the anti-allergic and the rest of all other ocular drugs. So I'll be taking questions now before we call it a day.
Hello, good evening.
Okay, good evening.
Hello, good evening, sir.
Yeah, good
How are
evening.
you,
Can
sir?
hear you.
Thank
Go
you
on.
for this wonderful presentation. Please,
All right.
what's the reason behind invalidity of ocular eye drops? I heard you made mention that when we start using ocular eye drops after 2 weeks and above, so they are no longer valid.
Yeah, from the last class, I explained stability of drugs and factors that affect stability of drugs. So I also said that some factors that's what we call degradation of drugs. So most drugs are prescribed for 2 weeks and asked to stop or discard after 2 weeks. Some are prescribed for a month and asked to stop and discard after a month. Why the expiry date is not yet, we have not yet reached the expiry date. So the reason is because of some factors. So drugs undergo degradation, and factors that causes degradation of drug is one, exposure to air. So when you open an eye drop, you've exposed it to air, degradation starts immediately. So most of these drops have a shelf life of 2 weeks. Some can extend to 1 month. So that is why most of these drugs are prescribed for 2 weeks, because it's assumed that after 2 weeks, the effect or the efficacy of that drug have reduced completely. So the degradation has occurred significantly, and this drug can become toxic to the eye. So that is why some eye drops becomes invalid after 2 weeks of opening. Some can be 3 weeks, some can be a month. So most anti-glaucoma drugs are for a month. And another factor also that influence degradation is preservative. So depending on the preservative this drug have, this preservative can keep it for a very long time. Apart from preservative, also the pH of that drug can also determine, because acidic medications, acidic drugs have higher shelf life than basic eye drops. So these are factors that affect validity of drugs after opening. You understand? Apart from air too, exposure to
Yes, sir.
um,
I get.
exposure to sunlight, exposure to moisture can also affect degradation. So all these factors causes degradation of drug. That's why some drugs, if you look at them, they are stored. Some drugs are stored in amber color containers. Some tablets are stored in amber color containers. Why? Because they are reactive with sunlight. When they come in contact with sunlight, degradation starts. So it's not advised. That's why it's not advised. Before you transfer a drug from one container to the other, you should know the reason for that container. You understand? So any other question?
Yes, sir. Thank you very much, sir. My second question is that I'm a little confused because you made mention that we can use steroids in the treatment of banal keratoconjunctivitis, but to be cautious when using non-steroidal anti-inflammatory drugs in that condition, that's banal keratoconjunctivitis. So I'm a little confused, sir.
Yes, even steroids too, you need to be cautious. Maybe I forgot to mention that using steroids and non-steroidal is very you need to be cautious, because these drugs can cause perforation of the cornea for cornea that is thinning. Hence, it can cause cornea melting for cornea that is thin significantly. So in VKC, in cases of VKC, there are some patients that develop cornea thickening in this condition, especially in children. So that is why in management of VKC, it is advisable to do a cornea topography to see the integrity of the cornea before while administering your treatment, so that you know how to take caution in administering steroids, because steroid is very effective in allergic conjunctivitis like VKC. So because of the effectivity of steroids, it's usually most of the choice of drug by doctors. So if you are conversant with, or if you are always good at prescribing steroid, you should take caution in cases of VKC, especially when this VKC have to do with cornea thinning. You understand? In order to avoid cornea perforation or cornea melting. But there are cases of after treatment of VKC, the itching stops, natrantas dots resolves, but this cornea became opaque. So it's very important to take note of that.
Okay, sir. But please, is there any treatment apart from using steroid or NSAID in that treatment of BKC? I mean,
Yeah,
other
if you
alternative treatment.
Yeah, there are other alternative treatments. There are anti-allergic medications. So you can go for anti-allergic medications in any of the classes, either an antihistamine or a mast cell stabilizer and a decongestant. Any of the anti-allergic medications, they are available.
Okay,
Drugs
sir.
like
Okay, sir.
Antalarge and Ocularge, loratadine, Piriton, and the rest of them.
Right, sir.
Olopatadine,
Thank you
and
very much.
welcome. So any other question?
So, sir, please, I don't know if can we get the soft copy of the slide, because where I am now, I experienced some network issues while you are presenting.
Thank you to everyone.